Hi, I'm Jiahe. Today I'll present using machine learning for non-invasive prediction of liver steatosis in individuals with severe obesity. Severe obesity affects over 40 million adults in the US and greatly increases the risk of liver steatosis and progression to significant liver disease. However, liver biopsy, the diagnostic gold standard, is very invasive, costly, and not practical for large-scale screening. Non-invasive tools like ultrasound and CAP also show poor reliability in severe obesity due to technical limitations. So we need a simple, reliable method to flag high-risk individuals early using routine clinical information. The objective of this project is to evaluate supervised machine learning methods in predicting biopsy-confirmed liver steatosis, using only standard demographic, clinical, and laboratory data. We analyzed a publicly available dataset of bariatric surgery patients with liver biopsy records from the Cleveland Clinic. After exclusion, the final dataset included 388 individuals and 12 predictors with a binary steatosis outcome. Numeric predictors were standardized using the training set. Although some collinearity existed, such as AST with ALT shown in Figure 1 here, variables were retained to preserve predictive signal. 9 machine learning models were trained and compared. Data were split into 70% training and 30% testing, stratified by outcome. Hyperparameters were tuned using tenfold cross-validation with AUC as a primary metric. Test set metrics included AUC, sensitivity, and specificity. Decision thresholds were selected using the Uden index. Let's first look at the training result in Table 1. Cross-validated AUCs were around 0.73 to 0.77. Boosting model performed best, where Figure 2 shows feature importance highlighted ALT, AST, followed by triglycerides and LDL, consistent with biological expectation. Now let's shift to the test set results in Table 2. AUCs dropped slightly to 0.65 to 0.7. Logistic regression reached the highest AUC around 0.7. Sensitivity was very high from 0.9 to even 1, while specificity remained very low from 0 to only 0.34. This indicates a tendency to predict steatosis positive status. Random forest and naive Bayes offer the most balanced profiles, but overall, specificity needs improvement. In the end, a brief discussion. Performance was slightly lower than some other published liver disease models achieving AUCs above 0.74. And I think some possible reasons could be class imbalance, limited feature diversity, and the small single-center dataset we used. Even so, the high sensitivity suggests potential use as a first-line screening or risk stratification tool, triggering further diagnostic evaluation when needed. Future work can consider first, adding lifestyle and metabolic variables, and then applying methods to improve specificity. Finally, validating models in larger and more diverse cohorts. Well, I think that's pretty much my project. Thank you, Adam and Megan, for all your help and guidance this semester. I really enjoyed the class. Happy holiday! Thanks, bye!